about getting off of these antibiotics? How about stopping eating when I'm full up? How about them transparent dangling carrots? How about that ever elusive kudo? Thank you, India. Thank you, terror. Thank you, this illusion man. Thank you.
Hello, and welcome to the Inside the Boards podcast, our Study Smarter channel. I'm Patrick Beeman, your host. Okay, I just had to throw this one in there. This is Mark McKenna, kind of a YouTube sensation from a few years back for this cover of Alanis Morissette's Thank You. The fam and I have been kind of rocking Alanis Morissette a lot lately. I don't know why. And, you know, it's kind of hard to secure music permissions from a big music group like Alanis's label. So this is a good alternative. Plus, it mentions antibiotics at the beginning. So, you know, highly relevant to our audience. At any rate, click the link in the show notes if you'd like to hear this full track, which I think is, you know, pretty good. Today, it's part one of our Pulmonary review for the Study Smarter series. But before we get into that, I just wanted to give a shout out to our sponsor, Common Bond. We partner with Common Bond, a company that helps medical students save money on their student loans. Not only have they helped thousands of healthcare professionals through refinancing, but they have also customized a loan for current medical students with rates that beat the federal Grad Plus loan. Forget everything you thought you knew about private loans. Common Bond has best-in-class protections and flexible repayment plans designed with med students' unique career paths in mind. Doing a residency, research, or fellowship after school? You can pay as little as $100 per month during that time. Need to press pause on payments? A Common Bond loan comes with 12 months of forbearance for financial hardship. It also comes with full death and disability forgiveness. Common Bond, the new way to pay for medical school. ITB listeners also get a $300 bonus when they sign up. Get started today at commonbond.co/ITB. That's commonbond.co/ITB. And now, let's get into today's show.
So welcome to the Inside the Boards Study Smarter series podcast. I'm here today with Matt Eisenstadt. He is he's emergency medicine resident who's going to be actually finishing at the end of the coming month. So congratulations on that. That's awesome. And then we'll be moving out for bigger and better things, right?
Yeah, thanks. Starting fellowship pretty soon.
That'll be another hurdle to jump through, right?
Yeah.
So he is with MedSchoolTutors, and he is here today to talk with me about pulmonology for step one, which is, we both agree, a very difficult and nebulous topic that we're not always finding ourselves utilizing the way you would think you do in medical school. So let's get into it here. So I'll start, like Patrick and I have been doing, we're going to read the answer choice or the actual question first, and then we'll get in with the vignette, and then we'll talk about the answers. So for this first question, which of the following has the patient had significant exposure? So the vignette here is, a 47-year-old man comes to the clinic today. He has a chief complaint of progressive difficulty breathing and shortness of breath. His social history reveals an occupation that clues the attending physician into ordering PFTs on the patient. The FEV1 to FVC ratio comes back at 90% with a significantly reduced FVC. This points to a restrictive lung disease, and endoscopy with biopsy confirms the diagnosis. The physician counsels the patient that his condition puts him at increased risk for infection by tuberculosis. So again, which of the following has this patient had significant exposure? Is it A, asbestos, B, beryllium, C, coal, or D, silica? All right, Matt, how would you kind of approach this question?
I really like the style of going through the final question first and then going through the vignette before you go over the answers. So that's how I generally will teach students to try to tackle these questions. This is a question about pneumoconiosis, and you can pretty much bet that any question on this is going to have these 4 answer choices in front of you, and there's really not a whole lot of variation on how they ask this question. The big thing, this is a buzzword heavy kind of question, in that you either have to get a buzzword from their occupation or some other little ancillary fact that helps clue you in to this. So these patients all kind of look the same in terms of symptoms, and they're all going to have pulmonary function testing that is consistent with restrictive lung disease. So they'll come into the clinic, they say they have a dry cough, maybe some hypoxia, maybe some weight loss. Chest x-ray can be helpful, but it's not super specific. And so basically anytime you get this question, you're either going to get the person's occupation or you're going to get some other factoid like they do in this one, which is kind of a newer play on the question in terms of risk factors for other diseases.
Yeah, I think this one kind of turned it around here. So this is asking, basically, it's a pneumoconiosis. They have a restricted pattern. And then the hinge here is that there's an increased risk for TB. For me, when I think about that, like this is a really factoid-based question. So you had to know one of these causes TB to be at a higher risk for the patient. Sure. And usually we think of things that are going to be causing cavitary lesions or something to occur where there's probably some space occupying mass or place for an infection to take hold, right?
Yep.
And that's why the answer for this one is going to be D, silica. Like you said, all the different answers are going to be causes for a pneumoconiosis, but silica really builds up in the lungs and can be a nidus for this tuberculosis infection. There are a couple of other buzzwords for it. So you think of, for pneumoconiosis with silica, you think it occurs more so in the upper lung fields. There is this characteristic eggshell calcifications in the hilar lymph nodes. And usually, a lot of these questions will be like, this patient is a sandblaster by occupation, or they do work brushing metal or something like that. And they'll ask you, what compound are they being exposed to? That would be like another way they might go about asking this question. I think all the pneumoconioses increase the risk for cancer, and as well as cor pulmonale. Some other kind of important buzzwords or associations to make are asbestos, which can cause a pneumoconiosis. More likely can also cause bronchogenic carcinoma, so lung cancer. And then the classic question that you might see is an asbestos patient, and that they may say, what are they most likely to develop? And they'll put 2 answers. There'll be lung cancer, and then there'll be mesothelioma. And the answer there is lung cancer, depending on how they ask that question. The mesothelioma, while it's more likely, and you see the ads on TV or whatever, lung cancer is still like the most common thing that they're going to get from their pneumoconiosis.
Yeah, you always see those late night lawyer TV ads for mesothelioma, and I think a lot of that comes down to the association with smoking and personal responsibility in terms of risk for bronchogenic carcinoma versus mesothelioma. So mesothelioma still has some association with smoking, but only has more association with asbestos exposure than does bronchogenic carcinoma. You're always going to get asbestos is going to describe usually a shipyard worker is the stereotypical patient. Beryllium is going to be someone working for NASA, working on these advanced electronics is the occupation associated with that. Obviously, coal is going to be a miner. And so, just if they're going to give you an easy softball question, they'll usually throw in the occupation right off the bat, and that's pretty easy points if you know those 4 distinctions. The only other thing to add, I think, is asbestos is the only one that does have a tendency to involve the lower lobes because the particles are a little heavier. So that's the odd man out, and so that may be something that they pick on for a question. And I keep seeing this. This is not something that I remember being emphasized when I was taking the test, but the Kaplan syndrome with association with rheumatoid arthritis and pneumoconiosis nodules seems to be a big buzzword in all the updates on the review materials. So I guess that's a more new association that folks are harping on a little more.
Yeah, I'm not going to lie. It makes me think of, I'm in a family medicine clinic and I'll see these patients with RA and they'll have, a cough or something going on, and I'll listen and I hear some interesting lung junk and I'm like, man, do I want to get a chest x-ray and look? Just because I was reading about that syndrome and how it's kind of, like you said, it's in the review books now.
Curious as to how common it actually is.
Or how often it gets worked up, Mm-hmm. And it's one of those things that you'll find that there are some of these diseases that just never get a workup. When you get into the clinical side of medicine, you have to be really chasing things down to find that sort of thing. One of the, I'll give a mnemonic from first aid because it kind of leads back to your asbestos comment. It says that asbestos is from the roof, where it's commonly found, and it affects the base, so the lower lobes, whereas silica and coal are from the base or the earth, and they commonly affect the roof. Okay, so the roof is the upper lobes, or in this case.
Yeah.
Yeah, it's interesting. So kind of one of those things where it doesn't make sense because it's reverse. Yeah. Use it if you like it. Ready to move on?
Yeah, let's do it.
Sure. All right. Would you want to take a stab at this, or I can read it?
Yeah, I got it. So 21-year-old male presents to clinic with a dry cough and fatigue for 4 days. He denies myalgias, nausea, vomiting, and diarrhea. Associated symptoms include headache. He denies recent sick contacts. He endorses subjective fevers and shortness of breath. His vitals exam and labs are within normal limits. His chest x-ray shows streaky infiltrates bilaterally. What is the most appropriate treatment for the patient? And so answer choices are oseltamivir, ceftriaxone, levofloxacin, or azithromycin.
So for this question, you have a patient that you're presuming has pneumonia. They have a dry cough. They've had a little bit of fatigue, maybe a little bit of fever. And then they have a chest x-ray showing that they have these streaky infiltrates. That is a description, I guess, of an atypical pneumonia versus like a lobar pneumonia. So you can think of atypical pneumonia as being more likely from atypical bacteria, or viral pneumonias can also cause an atypical pattern as well. Of course, you see the answer choices. So oseltamivir could be a viral pneumonia, so that you could leave it, but they don't have any like myalgias. They do have a mild headache, but no other this like kind of flu-like picture. So I probably would remove that. I don't really recommend giving ceftriaxone to many people for pneumonia that is atypical. Levofloxacin is more of a big gun as well. I guess you can give levofloxacin for something like a Legionella pneumonia, which they may have something like that would be like your atypical pattern with a hyponatremia and diarrhea as well is usually the pattern you see. But for standard community acquired atypical pattern pneumonia, you're going to treat with azithromycin. So you're looking here for something like a mycoplasma pneumonia.
Yeah, I totally agree. So there's a little bit of nuance to this question. If you dig into it, certainly the streaky infiltrates could be a viral pneumonia. Usually that is much more frequently in young kids. You'll see that. The other thing, so no nausea, vomiting, myalgias, which are more typical of viral syndrome, especially the myalgias on a test question. The one thing about oseltamivir, or trade name Tamiflu, is that all the data shows that it's pretty, in healthy patients who are otherwise okay to go home, pretty useless after about 48 hours. So we will generally not give it in a patient who's been having symptoms for 4 days. So just another, little side reason why.
Another nail in that coffin.
Another nail in that coffin. It's just, and I won't get into all the sketchiness of the oseltamivir research, but it's not a drug that we give lightly. You usually have to be pretty sick or coming into the hospital, a bunch of risk factors, or very, very young, functionally immunocompromised to get that drug. Ceftriaxone is a great drug for a strep pneumonia, a typical lobar type pneumonia, and it is part of the first line combo for someone coming in with a community acquired pneumonia, but generally more so for inpatient treatment. So ceftriaxone is only available in IV formulations and intramuscular formulations. So another thing you don't necessarily need to know, but it, again, just plays into the idea that overall inappropriate treatment, even though you'll frequently see that in pneumonia combinations as an inpatient. Levofloxacin or Levaquin is actually a really good outpatient pneumonia drug, but we save it for sick people. So levofloxacin has more activity against gram negatives. It has MSSA coverage, theoretical sort of pseudomonal coverage. So Levaquin or levofloxacin is a drug that probably was overused years and years ago and is now starting to fall out of favor for a lot of different reasons. There's a lot of resistance, especially in urinary tract infections, to fluoroquinolones. So we're trying to save them for really serious infections. So the indications for using Levaquin are someone with comorbid disease. So someone who's older, say age greater than 65, someone who's got COPD or diabetes, or is an alcoholic or an IV drug user, someone where you would be a little more worried about a more like gram-negative stuff, E. coli and Klebsiella pneumonias, MSSA pneumonias for like post-flu. That would be the time to reach for levofloxacin. But otherwise, try to save that one for the as a like you said, it's kind of a big gun, and seems to be a pretty wimpy, quote unquote, walking pneumonia. So Z-Pack and home. Exactly,
and that's what this is if you've been in the student health and gotten your Z-Pack, that's your azithromycin, and that it gets handed out pretty frequently. Maybe a little too frequently. I may not. If the answer if there was an answer that was I'm not going to do anything for a patient that's had this stuff going on for 4 days, that might be my answer. But, that's all debatable. But the important things, I guess, azithromycin, people for step 1 are really interested in how drugs work. So it's going to inhibit protein synthesis by binding the 50S subunit of the ribosomes, right? Which I always forget that kind of thing. And you will too after you take step 1. So get ready. But that's probably the one thing that I'll contribute to that discussion.
I'll pretend that I remembered that.
I know you did. Deep in your heart, if you had a question on it,
Sure did.
you probably would get it just by sheer reasoning, right? That's all I really had to say about that. So I think we can move on. I'm pretty comfortable.
Yeah.
All right, that'll do it for today. We will be back with part 2 of our pulmonary review on our next episode. What do we have going on that you should know about? Number 1, go download our iOS beta app and subscribe to our All-Audio Qbank with the Step 2 version powered by Online MedEd and the Step 1 version powered by Lecturio and Exam Circle. These are audio-optimized questions to help you study on the go. If you want to get involved and engage us a little bit more, interact with the hosts of our podcasts and ask questions about how to study or how to approach questions, go to bit.ly/ITB Slack. That's bit.ly/ITB Slack. It's a community where we are going to be fielding your questions for the podcast, taking your feedback, comments, and incorporating them into our show and into our platform, just so, we can get to know you a little bit better. And then finally, go check out all of the other podcasts that we are adding to our network. Of course, the ITB main channel, Physiology by Physeo, The Medical Mnemonist, and our newest collaboration with Physeo, USMLE Step 1 Success Stories. As always, thank you for listening. If you're about to take step 1, good luck, stay strong. It'll be over soon. And for those of you who already have taken step 1, thank you for supporting us and listening. We will be having even more third-year content coming your way in the upcoming months. Go tell your friends. We truly appreciate it.